Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we have the unique opportunity to talk to two corneal experts, Mayo's own Dr. Keith Baratz and Dr. Elisabeth Cohen from NYU Langone Health and Grossman School of Medicine. She was previously at Wills Eye Hospital and Jefferson Medical College. We look forward to discussing the research behind Valacyclovir to minimize the symptoms and sequelae of Herpes Zoster Eye Disease.
In the preparation for this podcast, we planned a journal club about a pair of articles from JAMA Ophthalmology, April 2025, regarding the Zoster Eye Disease study, or ZEDS. This led to the invitation of not one, but two corneal specialists to help us unpack this important clinical trial. Dr. Keith Baratz is a professor of ophthalmology and much appreciated corneal colleague here at the Mayo Clinic. During his tenure, he has served numerous roles in our department, including research chair, director of resident education, and as a member of the department's executive committee. His current research focus is the genetics and molecular biology of Fuchs dystrophy. He has participated in numerous clinical trials focused on the outcomes of corneal transplant surgery and was intimately involved with the ZEDS study as a study center and in the preparation of its publications and presentations. Given this topic, Dr. Baratz suggested that this episode would be particularly special if we could also invite Dr. Elisabeth Cohen. Dr. Cohen recently retired as professor of ophthalmology from NYU Langone Health Grossman School of Medicine. Prior to her time at NYU, she shared nearly 3 decades of distinguished service at Philadelphia's prestigious Wills Eye Hospital and Jefferson Medical College. She was the PI and study chair of NIH-funded Zoster Eye Disease study, ZEDS, that produced the data we will discuss today. Welcome, Dr. Cohen and Dr. Baratz.
Thank you for inviting me.
And me as well. Honored to be here.
As a pediatric ophthalmologist, I don't see much Zoster. Dr. Scruggs is a retina specialist, probably has a role more than me, but let's start for listeners that potentially are unfamiliar managing Herpes Zoster Ophthalmicus. How devastating can this disease actually become?
Dr. Bothan, I think the word devastating is accurate. We see in corneal external disease a lot of patients with herpes zoster, the sequelae of herpes zoster ophthalmicus. And I start my discussion with these patients saying, this is one of the toughest diseases we have to manage. And I think that tells the patient that, yeah, you have a problem, acknowledges the challenges they're having. One story I remember is I had a patient had very severe herpes zoster ophthalmicus, bad postherpetic neuralgia, ended up in the hospital, and she was so ill that her husband lost 10 pounds. So it's devastating, particularly for older people who have the postherpetic neuralgia. Some of these eyes ended up blind, or sometimes even worse. I think now with the new treatments, the way we approach our clinical care, suppressive medications, antivirals, that I think it does give these patients a better shot for sure. But again, it's a devastating disease.
Yeah, so Dr. Cohen, before ZEDS, before this study, can you tell us how variable the management was before we had these data? Like, what were people doing to manage this disease?
Well, for many years, we've had the recommendation for 1 week of high-dose antivirals, 7 to 10 days of Valacyclovir or 7 days of Valtrex or Famvir. So that's been the routine. You should do that as soon as possible after the onset of the rash. But it's best within 3 days, but if the rash is still active, I think it's good to do it even beyond that. So we've had that antiviral treatment, I think, since the mid-90s at least. And then beyond that, the eye part generally kicks in about 2 to 4 weeks after the rash. And the approach to that has generally been using topical steroids in variable amounts. I know that, for example, when I had herpes zoster ophthalmicus in 2008, and I was taken care of by my colleagues at Wills Eye Hospital, so I got the best care then. I was seen very frequently, about 55 times in 1 year before I lost enough vision not to be able to operate anymore. And every time I got worse, they'd give me another week's course of the high-dose antiviral. But really, people back in 2008 were not using suppressive antiviral treatment for herpes zoster like we were doing routinely by then for herpes simplex eye disease.
And just as a reminder to the listeners, reading the papers, it was pretty striking how common this is. So herpes zoster, at least one of your papers said 1 million people are being diagnosed with that, and 8% have ocular findings. Is that accurate?
Yes, I would say at least 8%. And one of the worrisome trends is that we tended in the past to think of this as a disease of older people, but it's not, because the mean age of shingles is decreasing. So the mean age is actually in the mid-50s, meaning that we see patients who are young 50s.
When I got zoster in my 50s, my first reaction, I was a little young. And so one of the first papers we did at Wills Eye Hospital was looking at all our zoster patients, and we found out even back in 2008 that half of our patients were under age 60 at their time of disease onset. So I think although it does increase with frequency in older people, and it increases in severity with regard to the chronic pain syndrome in older people, it is certainly not a disease just of the elderly, although the definition of elderly changes over time.
So with your own personal journey and appreciation for how challenging this condition is, and the backdrop that you said we managed herpes simplex different than zoster, tell us about the foundational thoughts and debate, whether it in cornea meetings or in your own kitchen, on how to answer this question as to whether or not chronic suppression in zoster would be beneficial. Tell us the story about how the ZEDS study came about.
Well, I had the idea in 2010, while I was retiring from Wills, because I could no longer be a real cornea doctor. Why don't we treat herpes zoster in the eye the way we treat herpes simplex in the eye with suppressive antiviral treatment? And I called a friend of mine who was chair at a big institution and said, what do you think of this? And they did a survey and found a lot of interest. And that was the end of that. And then I went to NYU. My first work was related to increasing use of the shingles vaccine that was available then. And then Hurricane Sandy came along and things were pretty quiet. And my husband said, you write the grant, you do it. So I took a year to write the first grant from 2012 and submitted it in September of 2013. And at that point, we did surveys in preparation, and we found a good amount of interest among cornea doctors to participate. They had a lot of patients, and they were kind of open-minded about whether or not suppressive antivirals would work. And then it took 3 tries at the NEI to get funded. And along the way, I got the Castro Vallejo Medal and talked about it to a broader audience. And a lot of the academic cornea doctors just started using suppressive antiviral treatment. And that's something that hurt our enrollment once we got going.
So let's summarize the study. So for this study, it was across 95 sites, and that included US, Canada, and New Zealand. And for that 12-month period, the first 12 months, patients were dosed with 1 gram of Valacyclovir. And then after stopping, they were also studied for 6 months, up until 18 months of the study. And my understanding is that 460 patients completed that 18-month period.
Yeah, I would like also to add that our traditional teaching, meaning traditional when I was young, was that there's no need to treat zoster after the first week because there's no active virus. But there's a study over a decade ago that really turned everything on its head. It was pertaining to mucus plaque keratitis. That's the relatively uncommon condition where patients months or years after having the initial shingles developed dendriform lesions on the surface of the cornea. And we thought that was some unusual type of surface disease. Didn't really have a good treatment for it other than supportive care. But there's a good study in a small group of patients showing that these were persistently PCR positive for zoster viral DNA. And this completely changed our thinking that, oh my gosh, we have patients who are still shedding virus months or years after their shingles.
Yeah, so clearly you knew that people were being undertreated at that point if they were only getting treatment for a week.
Correct. And that also changed our whole mindset on could there be persistent virus in iritis, stromal keratitis, necrotizing keratitis.
Yeah, that makes a lot of sense. So for the listeners, this study is the patients were dosed for 1 year at 1 gram of the Valacyclovir. 460 patients completed 18 months of the study. And so they were treated for 12 months, and then that last 6 months were just being followed. This was over a lot of sites. So 95 sites participated, US, Canada, New Zealand sites. So my question, Dr. Cohen, is really regarding how did you design the study? Specifically, why did you choose 1 gram daily for the Valacyclovir, and why did you choose the 12 months for the timing?
So the study a lot was inspired by the HEDS acyclovir prevention trial, where they did 1 year of acyclovir suppression in patients with herpes simplex eye disease and followed them for 18 months. And we did surveys of through the Cornea Society and through big fellowship lists of our cornea doctors, and we asked them about Valacyclovir versus acyclovir versus famciclovir, and the preference was for Valacyclovir. Valacyclovir is a prodrug of acyclovir. It wasn't available at the time that the herpetic eye disease studies was done, but it has less frequent dosing, better bioabsorption, and higher blood levels. And we picked 1 gram per year because that is FDA approved in the label for the treatment of suppression of genital HSV infection. So we needed to have an FDA IND because we were treating a different patient population, but we did something with a very long safety track record with a lot of data on its safety profile.
So as you reached out to sites, you obviously hit a common curiosity and concern to get that many sites involved. How hard was it, though, to get that many sites to agree on the protocol, on standard definitions for inflammation? You know, sometimes it's like herding cats to get everyone to agree on what they can study and be equipoised about. Share that journey. Dr. Baratz, you were probably part of some of those discussions. Was it sort of uniform agreement?
That wasn't the hardest part of the study, the protocol and getting sites interested. And in terms of the definition of the disease manifestations, I used the same ones that were approved for herpes simplex eye disease. I used the same definitions of epithelial keratitis, stromal keratitis without ulceration, endothelial keratitis, and stromal keratitis with ulceration. And for iritis, I used the uveitis definitions. So I used accepted definitions. And then we planned it with a study design session, and we pretty much had the protocol, and all the investigators didn't have much input on that, other than the people who were there at the very beginning.
But certainly to get that many engaged, they supported it, which is phenomenal.
They supported it, but then they went ahead and treated without rather than enroll. One of my less favorite people on the executive committee said, well, I'll give everybody a year and then take them off for a month and let them be in the study. And that was not what we wanted.
Sure.
Especially as it turned out with persistent treatment benefit.
Well, at least you were able to enroll the numbers you were. Can we transition then, given the background and given the structure of this study, what were the results and what surprised you or didn't surprise you?
Well, the study design was for the primary endpoint to be at 12 months. And for that, we did not reach statistically significant benefit, though we had a 23% reduction in new or worsening disease. At 18 months, we had a 27% reduction in new and worsening disease, and that did reach statistical significance. In our design, we had 4 strata. We hypothesized that recent onset cases would do better, but we divided for randomization by recent onset less than 6 months since disease diagnosis versus 6 or more. And we also felt that the disease manifestations could vary by age, especially the pain component that we also studied. And so we randomized by under age 60 at the age of onset and 60 or older. That design made it so the analysis was in 4 strata. And somehow or other, it became so that if you combined recent onset, younger and older, that was a post hoc, ad hoc analysis and couldn't be used for the primary outcome. In my mind, I assume we would combine those from the start. And if you do combine recent onset, younger and older, we found a statistically significant benefit at both 12 and 18 months. But that's considered a secondary analysis, not the primary result of the study. And many people were just fixated on the one primary outcome and have used that to undermine the strength of the study.
The study included these 2 articles in JAMA of Ophthalmology 2025, but this January, I think, in Ophthalmology, there was another look at the data with a Bayesian statistics analysis. Dr. Cohen, can you talk about what that statistical analysis brings to the table?
I can. I learned about this along the way myself. One of our multiple PIs is a clinical trialist in cardiology, and she was very familiar with the power of Bayesian statistics, as was our other multiple PI, who's a statistician and head of statistics in our population health department. With p-values, the idea is the 2 numbers that you see with study treatment versus placebo, do those numbers differ by chance, or are they really different? And in Bayesian statistics, it's different. You're testing the hypothesis, not the numbers. So what is the likelihood that the hypothesis is true? And there's a wonderful book by Tom Shivers that really explains Bayesian analysis for the non-statistician. And I think I highly recommend it. It's very readable and everything. But what it does is it also is very helpful in more nuanced guidance for clinical implications in clinical care. And so in the Bayesian analysis for recent onset, each of the 2 recent onset stratas done separately, not combined, we saw that there was a 65% likelihood that there was a greater than 9% absolute reduction in endpoints. So if with placebo you get around 30%, then you would have a 65% likelihood of greater than 9%, meaning you're going to have less than 21% outcomes, which is very important, and that was our original goal. What was also came out here is that the drug did not work very well for chronic disease. So it underscored the importance of starting this suppressive treatment soon after the diagnosis, at least within 6 months.
I have a question about the results, and I'm curious if you, as the PI and the authors of this study, were surprised by the persistence of benefit after stopping the Valacyclovir, and specifically if that result is different from HSV in the HEAD study.
Okay, want me to go first? We were surprised because in the Herpes Eye Disease study, the treatment benefit ended at 12 months and the recurrences went back up. In retrospect, however, I think Herpes Zoster has fundamental differences than Herpes Simplex eye disease in that Herpes Zoster has a rocky, rough course for a year or so, and then it kind of peters out and you just have to find the right amount of steroid to keep the patient quiet. So I think if you suppress the virus early on for a year, that's why we saw the persistent benefit. And I don't think there was like really greater benefit, but the difference between 23% and 27% was the difference in statistical significance. But again, going to clinical significance, a 4% difference isn't that much. But I think it was good news, and I think it argues against thinking that our zoster patients need to be on suppressive antivirals forever the way our herpes simplex patients do. In herpes simplex eye disease, someone might be quiet for years and then come in with a full-blown episode. And in herpes zoster, it's not that way. Again, it's a rough first year, and then it kind of, you figure out how to manage it.
So Dr. Cohen, along similar lines, just trying to apply this to clinical scenarios, what about that patient who even years later is still having a rocky course, requiring high-dose topical steroids and recurrences? Would that make you rethink whether to continue?
I would definitely use it for that person, because in the original analyses, we had statistically significant benefit in reducing multiple episodes. So these would be at least the third episode of keratitis or iritis. And we know that those multiple episodes are what go on to neurotrophic keratopathy, scarring, and loss of vision. So I do believe that if you have chronic onset, but you're still having a rocky course with recurrent episodes of inflammation that aren't like just triggered by a change in steroids, perhaps, I would definitely go ahead and treat. As you said, the zoster dendrites, dendriform epithelial keratitis, we know is positive. There's also data that the iritis is associated with PCR positivity in the anterior chamber. So I would add those persons. I think you want people with good kidney function. Didn't have to be perfect. I think it's not a bad idea to follow EGFRs like we did in people with below normal kidney function. People shouldn't be pregnant or wanting to become pregnant. But if they're adults and they have chronic disease and they're having recurrent episodes, I definitely would recommend it.
Yeah, agree strongly.
In the articles, it did stand out that when you looked at the number of episodes between the treatment group and the placebo group, the control, you're right that the driver or the biggest contrast was actually in the recurrence numbers of higher numbers of recurrences. Some of them had 5, 6, 7, high numbers of recurrences, and those were all in the placebo cohort, where at the lower numbers of recurrences they were more equal. Did that surprise you, or was that in some way consistent with the results of the study?
That wasn't so surprising. And one of the surprising results of the HEAD study was that it was most beneficial in people with stromal keratitis, which we think of as being more inflammatory and immune mediated. But clearly, if antivirals reduce it, virus is involved with triggering it. And I think that's the same thing that's going on in herpes zoster.
So you mentioned these 4 groups: age, duration of disease, certainly the clinical findings supporting this diagnosis. How has care changed since this study?
Well, hopefully it is changing. Hopefully the recommendations are catching on. There was interesting data between the different strata. I think one lesson, as Dr. Cohen already mentioned, is that you shouldn't delay suppressive therapy. You should start it as early as possible in a patient who is heading towards a rocky course, a course with ocular involvement. I think that's probably one of the major lessons, but also getting the patient on the therapy. One big question that I have, and one way of questioning how should we translate this into clinical care, is what do you do from the start? You have a patient who has herpes zoster ophthalmicus day 1. We know to get that patient treated right away, hopefully within 72 hours, with a treatment dose, something like Valacyclovir, 1 gram 3 times daily for at least a week, maybe 2. But what do you do after that? Do you continue the Valacyclovir 1 gram a day until the patient has declared themselves as being an individual who would develop eye disease or not? And that's certainly a question to answer, but I would argue that you should keep a patient on that suppressive dose until you know what direction they're heading. If there's no eye disease, fine, stop it. But if there's any hint of eye disease, start that suppressive dose as soon as possible.
So, Dr. Cohen, you mentioned checking kidney function and labs. which clearly your team did, but for the clinicians listening who are potentially starting these patients on 12 months of treatment, how often would you want them to check labs? And also, could you talk to potentially some mistakes that clinicians make generally about herpetic zoster disease in the eye?
So we did EGFR before enrollment, and if it was 60 or above normal, then we didn't repeat testing. If it was 45 to 60, 59, we repeated the testing every 3 months, and we had no episodes of study medication related acute kidney disease. But I think that zoster often affects older people, and I think it's good to have a baseline EGFR so you know what you're doing. Below 30, I would be very hesitant to be adding a suppressive antiviral. Generally, you have to reduce the dose when the EGFR is less than 30, and we've already reduced it for the full amount from 3 times to 1, but we're talking about chronic use. And I think if someone has significant kidney disease, I would work with their kidney doctor and talk about it, because they also are immunocompromised when they have kidney problems. But I think the dose may well have to be adjusted. I think if you ask me, the biggest problem I see is that our patients aren't getting vaccinated with Shingrix, and they come in with zoster, and the first question is have you had Shingrix? And the answer is often no. I get emails still every week from people suffering from zoster, not necessarily near the eye, but having terrible pain, and they haven't been vaccinated. So if there's a message I'd like to get to ophthalmologists and to medical doctors, is to really strongly recommend vaccination against zoster to everyone starting at age 50, and to be aware that since 2021, the FDA has recommended it for people who are immunocompromised starting at 18. And immunocompromised includes all the patients on the immune modifying drugs for rheumatoid arthritis, ulcerative colitis, eczema, all the things being advertised on TV. And the coverage in general for 50 and above is still low. The CDC hasn't published the most recent results, but they were 20% the last go around. And I think they're even much lower for the young people who are immunocompromised. There's a lot of data that the immunocompromised are at increased risk, and you have to kind of time your vaccination for when their immune system is relatively strong, because the way vaccinations work is to get the immune system to respond. But I really think that I would like ophthalmologists, and this is something I think Dr. Baratz has written about, that we should be part of the solution of encouraging the use of vaccination against shingles. We have a very effective one, although I think more than 15% of people will have moderate to severe feeling lousy like the flu, can't get out of bed, or an arm they can't lift for 2 or 3 days after, and you have to have 2 shots and be prepared for side effects.
Yeah, let me emphasize that age 50 is CDC recommended. Again, we tend to think of zoster as a disease of the elderly, which we've also discussed is not necessarily true. And the previous vaccine was recommended for older individuals, but the Shingrix is recommended starting at age 50. So, don't delay that vaccine until you're 55 or 60 or 65. You're recommended age 50. The long-term data on the vaccine are quite good, that the effect of the Shingrix lasts for many years, which also is much better and a benefit compared to the prior vaccine, the Zostavax, which tended to dwindle after 6 or 7 years.
Are you seeing zoster in patients that have been vaccinated?
Yes, we have. Not many. Yeah. Not many. And I would say we're not seeing as much zoster of the eye that we used to. I think primarily because if it doesn't happen, you don't see them. Yeah. We haven't studied it carefully. Dr. Cohen, are you aware of any data addressing that specifically?
I know, though, that chickenpox vaccination has reduced zoster in the young kids, that attenuated virus is less prone to cause zoster. And, when all of us were born in the United States, before 1995 are gone, I think shingles should be less of a problem. Though it is shocking to me that civilized countries such as the UK and France don't routinely vaccinate their children with chickenpox under the erroneous, not evidence-based misconception that exposing adults to their kids with chickenpox prevents them from having zoster, because that's not true. You know, the rates of zoster are the same in the UK and France, even though they don't vaccinate their kids.
Can I transition to pain? So we are certainly aware that after herpes zoster, there can be debilitating challenges with pain. Kind of talk about kind of what that, and one of the two articles from this publication, from this series, had to do with pain. Tell us about the patients in general before this study, and then we're going to talk about the results of the study and how it affected pain.
Well, before the study and just in the past, devastating again is an appropriate word. The postherpetic neuralgia tends to be more common in the elderly, more frail, more fragile, and something like chronic pain syndrome can be disruptive to every aspect of their health. And to the point where I would see elderly patients with bad postherpetic neuralgia and I would fear for the longevity. I really would.
And I want to re-emphasize that, really, how bad this pain can be for the quality of life. I mean, I had a patient once who, sort of said, well, why don't you take out my eye? I want to get rid of the pain. But I said, we don't like taking out eyes that have vision, but it wouldn't get rid of the pain that he had in his whole distribution of the trigeminal nerve. I had other patients who were on such high dose of these neuropathic pain medicines that they were groggy, half asleep. I mean, I think those medicines have terrible side effects and make it so you just can't complain about the pain anymore because you're so tired. And another example, a lot of people would ask me what I was interested in, and I'd say shingles, and I would expect them to go on to the next subject. But oftentimes they would tell me about family members who are just devastated by it. And one of our friends whose parent had cancer, the end of their life was harmed by the postherpetic neuralgia that prevented them. It was thoracic, and someone couldn't hug them or touch them or be near them. So I think that the pain is a big deal. And the pain that they talk about, postherpetic neuralgia, it doesn't get defined till after 3 months. But oftentimes the pain is terrible for the first 4 to 6 weeks. And I get a lot of calls from patients like that. And what's very interesting about the pain of this disease is I think that's the reason that one of the ways that vaccination goes up is when someone has a relative or a family member or a close friend with the zoster, they go out and get vaccinated because they see how bad it is, even if you're only in pain for 4 to 6 weeks. I only had pain for 6 weeks, but it was terrible pain.
Can we talk about the results of that study and specifically the patients who are on 12 months of immunosuppression with, Valacyclovir, the 1 gram, and how do you counsel patients regarding the prevalence and what to expect when they are on 12 months compared to historically when we were only treating for maybe a few weeks?
The patients, how you counsel them? Well, approximately maybe 5th or 6th of patients have very significant postherpetic neuralgia. Okay. And unfortunately, once that starts, we don't have a way of stopping it. The patients who are being treated with the suppressive dose of Valacyclovir, it doesn't stop the postherpetic neuralgia. It doesn't make it go away. So it doesn't prevent it, but it probably blunts the effect. Some groups of patients had a lower pain score at 12 months, less medication usage. And the medications, they're most commonly used gabapentin and Tylenol, but the use of neuropathic pain medicines such as gabapentin and pregabalin is another one, was reduced in the patients who are on the suppressive doses.
And I really hope that a study is done. There was one thing I want to clarify. These aren't immunosuppressive. They're suppressing virus, right, or Valtrex. But what I would say is there's a tremendous need to study the use of Valtrex to help with pain related to zoster all over the body. And I really would hope that maybe Mayo Clinic would take the lead in this, because I think that zoster-related pain is not just for herpes zoster ophthalmicus, it's for all zoster, and you'll get many more study participants if you you do the study in people with zoster in any location.
That's a great cue to just talk about what other unanswered questions are there after your study. What would you like to see next as a clinical trial or research being done in this field?
And for me, it's looking at the use of Valtrex to reduce pain related to zoster in any location. Clinical trials are not for the faint of heart. They're very challenging to get funded, to get enrollment, lots of things. And so I think you aren't going to do a fine-tuning clinical trial. But I think that looking at it for zoster pain in general would be a really worthwhile thing to do.
My question, oh, go ahead.
I agree. And I would also look at it starting right away. And I think in zoster in other dermatomes would be a much easier thing to study. And you can enroll patients essentially right from the start, treat them for 1 to several weeks with a therapeutic dose, and then a suppressive dose for the following year. And that would answer a couple questions. You know, one, is it effective in other dermatomes? But number two, is it more effective if you start it right away?
I agree. Because you could start it during the acute pain, right? And see, you might prevent the post-herpetic neuralgia.
So with the last few minutes that we have, I have a question for the general ophthalmologists who are potentially listening. And this question is for both of you, but when do you want people to refer to you? When should they refer to a cornea specialist when a patient presents with zoster eye disease?
That's a great question. I don't think it has to be a cornea specialist who is treating the condition. I think it needs to be somebody who is diligent with follow-up. And in my opinion, the biggest mistake I see is that you have a patient, you may be treating them with steroids for stromal keratitis. You stop the steroids, they're doing well for a while, and say, come back and see me if you run into a problem. I think that's the wrong approach. I think one of the really important lessons we learned from the ZEDS is that when you follow patients every 3 months for a year and a half, you really get to see the natural course of the disease. And it's a very long, drawn-out condition. When we would make changes in the steroid dose, we would increase or decrease a steroid and then see them back. And then see them back again and again.
I totally agree, because many of our endpoints were relatively asymptomatic, picked up at routine visits, and they were mild disease. And if you can't wait for the patient to come back in because they notice a problem, and I think that's really important. And another point I would make is that I think it's good to, I'm biased, I think it's good to have cornea specialists involved, but they could be seeing the patients once or twice and be in communication with the doctors in between. I think one of the take-home points in the paper that was published on stromal keratitis is low-dose steroids, low-potency steroids work often as well as high-potency. I saw a lot of times that comprehensive ophthalmologists would tend to stop steroids, whereas I think that cornea doctors are more likely to taper, go to weaker steroids, go to less than every other day, and follow the patient and see the lowest amount of steroid they need to keep them quiet.
Yeah, and as you mentioned, if you wait for the patient to come in, at that point they've already lost ground. If they start noticing some change in vision, there often is an incremental decrease in vision permanently. So you've already lost ground. And like you mentioned, we would pick up cases of worsening stromal keratitis when the patient was completely asymptomatic. And to me, that's one of the really important lessons, is you just have to follow your patients, establish the minimum steroid dose necessary to control their disease, but just don't let them, don't let them out of your sight for too long.
I agree totally with what Dr. Baratz is saying, and I think it's not appreciated by general ophthalmologists. And it's a unilateral disease. So you can even lose vision in one eye and not be especially symptomatic.
Well, my last question is to you, Dr. Cohen. You have had a striking season regarding a personal story and leadership journey in this study. A lot of individuals deal with healthcare affecting their profession personally. And I just cheerlead what you've done. You were challenged. You shared a little bit your story and how it affected your career. And yet from that brokenness, you turned it into something that probably is going to affect way more patients than what you would have if you would have stayed in clinic yourself. So just, can you, as we close, reflect on your looking back at the last 15 years and this disease? What would you share with others as they are an ophthalmologist aging, realizing they can't do what they used to do, but yet still have curiosity to contribute?
Yeah, I think that when an ophthalmologist or a cornea doctor can't operate, it's a blow to how they have viewed their career. And for me, I focus a lot also on mentoring medical students. One of the most gratifying parts of my career was being the advisor for all of our students in the 3-year accelerated pathway. And the success of that pathway made it so the school is now a 3-year for everyone. So I think that there are lots of things one can do beside operate, although operating, I think, gives you the biggest thrill in our career. But I do think that you always need to see the glass as half full. For me, this disease made me stop commuting from my husband, so I was with him. That was good. But it has been the gift that keeps on giving, because I just had in my right eye, I guess, the 5th operation this past January. And it's just been one thing after another. So I have a new diagnosis this past month, and it has been a chronic journey for me. But I keep the eye shut and try to forget about it.
Well, thank you for sharing your story and your leadership to bring about this research. And thank you for being part of the podcast today.
Yeah,
and I want to thank Dr. Baratz, because he was an early supporter. He wrote an editorial very early on that he thought this was worth studying. And he and I share an interest and a commitment to external disease, not just eye surgery. And I think we're very patient-oriented, patient-centered, and feel that we are eye doctors, but doctors first, which I think is to be valued in our profession. And I have tremendous respect for him.
Well, thank you. Thank you. And I have a lot of respect for you to take on this study, especially it being such a personal journey for you. And herding cats, dealing with all the regulatory aspects of a study like this, and then the challenges of this particular study. Usually, I think prospective clinical trial, we've been involved in a variety of different studies. Usually say about 50% enrollment, about half the patients are interested or seriously interested in enrolling. Very different for this study. And the patients are so emotional about it. Some of the doctors are so adamant about whether the suppressive dose is necessary or not necessary. So there's a lot of irrationality involved in the disease because it's such a devastating thing. Patients are very emotional. It's hard to enroll patients, partly because they were very frightened to stop the medication if they were already on it, hesitant to restart, and just it was an emotional journey for them to take part in the study, which some of them were willing, but some of them wished to not get involved in.
And another point I want to make, though, is an individual who's determined can't do this alone. I had tremendous backing at my institution. You know, I had excellent trialists and excellent statistician. I had people with FDA expertise, people with grant writing, and it took not a village, it took a real academic medical institution that was integrated and committed to supporting clinical trials. And so that's why I think that it has to be done in big academic centers, and Mayo could do that, one for the zoster pain.
Well, thanks
We
again
could.
for sharing.
Good.
Yeah.
All right.
Thank you.
Okay. Thank you. Dr. Cohen, thanks so
Thank
much.
you.
Great to talk to you again.
All right, good to see you. Thanks for inviting me.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.